And as scheduled, this is you're all welcome. I think this will just be a good point to start straight away. Without taking so much time, I think we can just get into the day's proceedings. And I will be I'm so delighted. I should start with I'm so delighted to be able to welcome you to this truly pivotal moment in for healthcare in Africa. Today is coming on the heels of the World Health Assembly, and just 3 days after Africa Freedom Day. Indeed, we could say that this is part of the event marking Africa Freedom Day 2025. We can then all agree that this gathering has arrived at an opportune time. So before we go into today's proceedings, I am thrilled really to introduce the African Health Catalyst Forum, an initiative that embodies the collective aspiration of the 5 co-conveners for a healthier, self-reliant continent. My name is Edward Oladele. I am the CEO of Cutting Edge Public Health Solutions, the hosts of the African Health Catalyst Forum. For too long, we have lamented the challenges that face African healthcare. But today we stand at a turning point. We're past lamentations. We believe that Africa possesses the ingenuity, the resilience, and the spirit to forge its own path towards health sovereignty. The African Health Catalyst Forum was founded for just that. Founded by the 5 co-conveners, whom you will meet at the end of today's session, towards the end of today's dialogue. The forum was set to catalyze action towards improving health systems performance on the continent. It aims to unite African leaders, policymakers, researchers, NGOs, international organizations, communities, funders, and multiple voices, really, to drive actionable insights and foster collaboration that enhances African health outcomes. Now, let me say this. This forum is not just another talk shop. It is a dynamic ecosystem that is designed to ignite innovation, foster collaboration, and accelerate sustainable health solutions across the continent. Our vision is abundantly clear. It is to catalyze transformative change, to empower local communities, and build robust health systems that are resilient, equitable, and truly African-led. We are seizing the moment because the time for action is now. We recognize and acknowledge continental leaders who are also working and championing action in these regards. We are glad as the African Health Catalyst Forum to be able to contribute to this progress through our platform. To kick off this critical journey, you're welcome again to the first roundtable in the Seizing the Moment, Africa's Roadmap to Self-Reliant Healthcare series. Today's opening dialogue, A World of Opportunities, the Case for Reimagining Health, sets the stage for profound conversations that will shape our collective future. There are 4 roundtables in this series. You may have seen that on the flyers. Each of them will explore themes that are critical to healthcare resilience. Those 4 roundtables are also on your screen right now. And today is the opening dialogue. To guide us through today's vital discussion, we have an exceptionally distinguished individual, a true champion of African health. It is my distinct honor to introduce our moderator, Dr. Corinne Karim. Dr. Karima is the founder and the CEO of Africa Kwanzaa Health Impact, an African-led organization that is dedicated to accelerating malaria elimination through resilient country-owned health systems, something we really, really deeply need. She's a globally recognized public health specialist and a seasoned malaria expert. She brings over 2 decades of experience in malaria control and elimination across Africa and internationally. Our leadership has shaped global health policies through high-level advisory and governance roles with organizations like ALMA, the RBM Partnership to End Malaria, the Global Fund. She's a trusted technical advisor to the World Health Organization and the Bill and Melinda Gates Foundation. Dr. Karima has made substantial contributions to malaria policy and the implementation of the WHO Global Technical Strategy for Malaria, the one that runs from 2016 to 2030. She is deeply committed to strengthening African leadership and empowering women in health to deliver locally driven solutions. Dr. Karima's profound expertise, unwavering dedication, and visionary leadership make her just the ideal person to moderate today's essential dialogue. My job is now almost done. But before I say I drop the mic and hand it over to her, please join me in giving a very warm welcome to Dr. Corinne Karima. You can use reactions and in the chat box. Dr. Karima, over to you.
Yeah, thank you very much, Eddie, and thank you very much to the team for giving me this opportunity to moderate the first series of the Roundtable, Seizing the Moment, Africa Roadmap to Self-Reliant Healthcare. So good day to all the participants that are joining us across the continent and around the world. And as Eddie said, this series is hosted by Africa CDC with the support of many collaborators, including Cutting Edge, Public Health Solutions, EpiSolutions, PnP AHEAD, AHFID, the Jardin de Zoey, and the Policy Innovation Center. So I really urge you to go and Google them and know all the excellent work that they are doing. So today's session will set the tone for the upcoming discussion, and we are here to reflect on the present and how to reimagine the future of health in Africa. And as Eddie said, the objective is really clear. We need to frame this conversation by examining the current state of Africa health system, understand the limitation of the health dependency, and as he said, we need to stop lamenting. So we need to explore new opportunities for sustainable and locally led solution. So as you know, this conversation is really critical given the current global health financing landscape. We all know that there is the donor funding shrinking. It's really time that African nations strengthen the domestic resource mobilization. Africa CDC is on the call, so we need also to build robust public health architecture and then also drive integrated national investment in health. And for that, our effort must go beyond all the traditional silos. We need to have health in Africa be recognized as a core pillar of economic growth. So there are 4 principles of this call and webinar today. We need to be positive, so we are going to get solution. We need to be action-oriented, so we need to also focus on what it is and what can be done. And then we need to also to be forward-looking. So we are going, of course, to learn from the past, but we really need to advance with purpose, and that's why we have the Catalyst, the Africa Catalyst Forum. And then, of course, we need refreshing, hopeful. This is where we really need to be guided by evidence. So in today's webinar, we are privileged to have the welcoming remarks by Dr. Raj Tajuddin, who is the Acting Deputy Director General of Africa CDC. And he has a background in medicine and public health. He has been instrumental in driving regional response to major health emergencies, shaping Africa CDC strategies on epidemic preparedness and strengthening health system across the continent. So it brings deep expertise in health security, policy, and regional coordination. So please join me to welcome Dr. Raji Tajuddin for his welcoming remarks. Please, Dr. Taj.
No, thank you, Madam Chair, and thank you, fellow panelists. Let me, on behalf of Africa CDC leadership, under the distinguished excellency of Dr. John Kasia, welcome us all to this first in a series of webinar. And as colleagues have rightly mentioned, we are actually at a crossroad, especially on the continent of Africa, 55 member states, 1.5 billion people, given the event, that is happening now, which started some couple of months ago. So our gathering today is founded on the principles of respected, trusted, action-oriented partnership. As you rightly heard, there are a couple of partners who have put this together because we believe that situations like this require what I describe as 4 C's. It requires collaboration, it requires coordination, it requires communication, and of course, much more importantly, it requires us to cooperate, because that's the only way we can better support our member states, and address this issue head on. Colleagues, this webinar will also provide opportunity for us to discuss possible pathways or solutions, for the continent to come up with a roadmap towards a self-reliant and resilient health system that will guarantee both our health security sovereignty and guarantee our universal health coverage, especially that we are just 5 years towards the SDG 2030. So there's no better time to discuss this particular agenda. Colleagues, you also agree with me that most of our member states, talking of the AU member states, have navigated their health challenges with the support of international aid. I've had calls to visit countries and I've had calls to discuss with parliamentarians and ministers, without mentioning any country name. I want to let you know that some of our member states actually depend on international aid. They depend on development assistance, as far as financing the health system is concerned. But the event of the past few months, is really putting some of these countries at risk, In fact, this is so critical and it's so crucial that we really need to do something, because we are talking of 70% decline, as far as this official development assistance is concerned. And you also agree with me that most of these ODAs actually go into financing health. Colleagues, this decline is also an already fragile, weak healthcare system, and is putting our continent at the risk of another pandemic, with a very severe outcome. This cut is also putting us at the risk of excess mortality in the tune of 2 to 4 million per annum. And this cut is really going to reverse decades of hard-earned or hard-won gains as far as the healthcare delivery system is concerned. In 2001, our head of state and government met in Abuja, and they all agreed that to effectively and efficiently finance our health system, 15% of our national budget should go into the health sector. Today, we have only 3 countries, I repeat, 3 countries, who have either consistently achieved or even surpassed that target of 15%. And these countries are Rwanda, Botswana, and Cabo Verde. Most other countries are nowhere near that 15%. In fact, we have some countries who are actually below 5%, just to tell you how bad the situation is. Colleagues, if you continue like this, we risk another pandemic, as I mentioned, because already we have seen repeated increasing frequency of disease outbreaks as far as the continent is concerned. We have moved from 150 per annum to over 200 per annum, talking of 41% increase in disease outbreaks as far as the continent is concerned. So what do we need to do? And I, as Africa CDC, taking the bull by the horn, with support of our member states. So we have launched what we call the Africa's Health Financing in a New Era initiative. So this has enjoyed a lot of political buy-in from the level of our ambassadors, to the level of our ministers, and to the level of our head of state and government. As you are all aware, the Africa CDC is a specialized technical institution within an intergovernmental political organization. So we are leveraging that platform to advance this agenda, much more importantly, to build the capacity of our member states. And this health financing in the New Era initiative is underpinned by 3 critical pillars. Number 1 is to increase domestic financing for health, working under the leadership of President Paul Kagame of Rwanda, who is the African Union champion for domestic health financing. The second pillar is around innovation, innovative financing for health. And the third pillar there is blended financing. And a cross-cutting enabler for this pillar remain governance and efficiency in the way we utilize those resources. Colleagues, the journey to self-reliance is no longer a choice. If we think it's a choice, the events of the past few days clearly indicate that it's now an imperative. This series of Roundtable, Seizing the Moment, Africa's Roadmap to Self-Reliant Healthcare, is not a forum for us to lament on the past. Rather, it's for us to forge a future, that will guarantee air security on one hand, and also guarantee universal air coverage on the flip side of that. This webinar series, Virtual Roundtable, designed to bring together stakeholders in the health space as far as our continent is concerned. And this discussion aims to explore, propose, and share actionable solutions that will empower African healthcare stakeholders to pursue and implement sustainable and trusted health program model beyond traditional aid-funded model. Colleagues, ladies and gentlemen, it's our collective shared responsibility for the effective implementation of this roadmap for self-reliant healthcare, the new Africa CDC financing initiative, as well as our new public health order, clearly articulate the importance of health financing. Colleagues, ladies and gentlemen, I would like to stop here and let you know that as Africa CDC, we'll continue to work with our member states. We'll continue to work with all the partners in the room, to make sure that we are able to come out of this, I don't want to call it crisis, but come out of this challenge together. So thank you, and over to you, Madam Chair.
Thank you very much, Dr. Tajuddin, and thank you to lay out the new framework on health financing with the three pillar. And it's clear under the leadership of Africa CDC, we need combined effort, we need partnership, and then the importance of leadership in Africa. So thank you very much. So we are going to go to a panel. We have three distinguished panelists. So we have Dr. Osundo Ogbuoji, who is a physician and health economist, whose research focuses on improving the performance and equity of health system in low and middle income countries. He is an assistant research professor at Duke University and deputy director of the Center for Policy Impact in Global Health. We also have Dr. Adebobola Bashorun, who is the director of the National Coordinator of Nigeria National HIV/AIDS, Viral Hepatitis and STIs Control Program under the Federal Ministry of Health, with close to 25 experience in spending in clinical medicine, public health and health policy. And we also have Professor Kenneth Gure, who is a respected public health researcher and educator at Jomo Kenyatta University of Agriculture and Technology in Kenya. His work focuses more on HIV prevention, community engagement, and implementation science, particularly at the intersection of research and public health delivery. So we are going to begin with an opening thought from each panelist, move into moderated discussion rounds, and close with a final reflection. So to each of the panelists, I'm going to ask if you can reflect on the urgency and opportunity this moment presents. You heard from Dr. Tajuddin on the current global health architecture, as well as the African system, and also the level of the financing of health in Africa. So how does your work illustrate the transition from AIDS dependence to homegrown solution? So I'm going to start with Dr. Osundo Ogbuoji, please.
Thank you very much, Madam Chair, and good day, everyone. It's a pleasure to be here, and I'm happy to be able to be part of this very important discussion. It was very nice also listening to Dr. Raji deliver the opening remarks, and equally pleasant to know that Africa CDC is doing a lot to solve this problem. I currently co-lead a policy lab at Duke University, and a lot of what I'll be saying today is based on research that we've done over time. And we have studied this question of donor exits and transitions for middle-income countries. We were primarily focused on middle-income countries that lose eligibility for concessional financing over as they experience economic growth. So we looked at 3 African countries and 3 countries in Asia. The African countries were Ghana, Nigeria, and Kenya. And we also looked at India, Myanmar, and Sri Lanka. And we learned a lot of lessons from those experiences, because we talked to the countries and we also talked to the different donors. We looked at 7 big donors. And all those lessons point to the fact that it is possible to move from dependency to self-sufficiency, but it's not easy, and it's by no means guaranteed that a country will be able to make that leap. But if the country is serious about it, it is possible to do that. So African countries, if we are very, very serious about making that leap into the new era of decreased donor funding for health, we can achieve it. And we already know that Africa has different kinds of challenges, but at this point, there are many African countries that are not very dependent on donor funding. They have less than 10%. So if you look at the countries in Africa, about 16 countries, about 27 countries have donor funding accounting for less than 20% of what they spend on health. On the flip side, you have about 24 countries that households spend more than 40%. So where in those countries, households collectively spend more than donors spend on health. Why am I putting this here? I'm putting this out there so that we understand that even though this problem seems difficult, the solutions might be easier than we think, because not all the money that's not coming will be needed if the countries decide to cover that gap. So to the original point, this problem is big. Solutions might be simple, and this is an opportunity for African countries to look inwards, to think differently, and take bold steps to tackle this challenge. I yield back to you, Madam Chair.
Yeah, thank you very much, Doctor. I see that you are very optimistic. So I'm going to ask to Dr. Bashorum, what are your views and how can you reflect on the urgency?
So thank you, Madam Chair, Madam Moderator. Good afternoon. So I would say this is an important session for every African country here. And like Dr. Tajin Raji, representing African cities, has spoken, he has indirectly given us our scorecards. And it shows that we need to do more as a people, as a continent. Now, in terms of spendings, a lot of African countries have depended so much on development assistance, that is donor funding or development funding. And it's coming suddenly for us now to realize that we just have to have a response plan to address the gaps that will be created. And even when we had a lot of this funding support in the past, probably in the last few years, we still had some challenges with our health indices. So now that the funding is no more there, it's even more of priority for us to deal with. And something key that we have to consider is efficiency. Efficiency in terms of the little we have, how best can we use them? And in the past, when we're under donor funding, we don't build more into the efficiency model. We do more of this money is coming from outside, and some of the conditions attached may not provide that efficiency. So this time around, we need to also strengthen our transparency, our accountability, and build an efficiency model that will be able to use our local resources to achieve more. And even as a country, Nigeria is already working around that. And like I said, Africa, the scorecard Dr. Raji gave us today is clear. We already know the problem. Our work now is to find the solutions and sustain the solutions and the gains over the few years. So for the many years that the donors have supported us, we definitely have made some gains, definitely. And at this point, we should not depreciate on those gains. Rather, we should sustain them and also, if possible, improve them, but we should never go down on this. So local funding we support, but we have to build efficiency model urgently and interventions rapidly. Thank you. Over.
Thank you very much. Professor Nguru.
Good. Thank you. I'll start by thanking the African Health Catalyst Forum for organizing this timely forum. As the old adage says, every crowd has a silver lining. The very dark crowd created by the suspension of US funding, especially HIV-related research funding and also funding related to programs, has provided an opportunity in our African region to start looking for sustainable solution from within. And this is being done urgently. I was just in a local meeting in Kenya, in one of our rural counties last week, and the local leaders were working in partnership with health providers, exploring collaboratively on innovative approaches such as integration of services to move from the mostly donor-dictated vertical programs. meaning that clients will see fewer providers and be able to access services. For example, as you have said, most of my work is on HIV prevention. So some of the models that were being explored is, for example, combining family planning and HIV, so that when clients who need family planning services and contraceptive services can get this at one stop. And there are many other innovative approaches. And as we're saying, it's not one size fits all. So as we are thinking about these innovative approaches, they may be different by counties, they may be different by regions. The most important thing is that they will be locally acceptable. And this will create an overall efficiency in the system. And there are many other examples I'm sure many of your countries are exploring. And as I said earlier, I'm a HIV prevention researcher. And most of my work has been funded by the donors from the Global North. And we have also started looking inwards and starting to wonder, can we get some of funding from the national government? Can we move from the non-traditional funders and create research that is also responsive? Remember, there another adage that says, who pays the piper calls the tune. So when we develop our own local funding, we'll probably be able to do research that is also more locally relevant. And so in summary, I want to say that we have no option but to create sustainable models of health for both research and programs to address our local needs. And it's a situation of win or win. So thank you.
Thank you very much. So we are going to unpack the conversation, but we also want to take benefit of the presence of Dr. Tajuddin. So Dr. Tajuddin, I know that you are too busy, but it's really important that we hear from Africa CDC. So what role can regional institutions like Africa CDC play in amplifying African voices, guiding funding norms, and pulling cross-country capacity to reduce fragmentation? So on top of what's the excellent work that you share with us in your opening remarks, we would like to hear more from you.
Thank you. I mean, Madam Chair, let me acknowledge the fellow panelists. Usondu, good to see you. My brother, Basharon, always a pleasure. And Prof, good to see you as well. No, thank you, Corinne. You know, as I mentioned in my remark, the Africa CDC is an intergovernmental, institution, technical, but sit within a political organization. So that in itself is an advantage. So when this issue, started late 2024, first thing we did was to reach out to the political leadership, you know, and as some of you are aware, we did convey a meeting of our head of state and government to give out direction, you know, on the margin of the AU Summit 2025. And that meeting took place February 14 under the leadership of President Paul Kagame of Kenya, of Rwanda, who is also the champion, you know, for domestic health financing for the continent of Africa. So it was based on the outcome of that meeting that we developed this rethinking health financing in a new era. It was based on the directive from our head of state and government. So meaning that as Africa CDC, we have what it takes to leverage the political leadership on the continent, which we have done. Number two, for Africa CDC and by extension the African Union, is to convey other key stakeholders. You know, so after getting that guidance from our head of state and government, we brought the ministers of health together, you know, on three different occasions so far. One on the margin of the AU Summit, second one was virtual, and the third one was just a few days ago on the margin of the World Health Assembly on May 17 to further discuss this issue, you know, so that we have alignment, you know. So that's the second thing that Africa CDC can bring to the table. Number three is to work with the key partners, especially the global health initiatives, you know, because they are key and critical to this discussion. You know, so we've been able to bring them together, the Gavis, the Global Fund, the Global Financing Facility, the World Bank, you know, and the other key partners, you know, who are in this particular space, including the UNICEF, you know, to see how do we ensure efficiency in whatever that is going to be coming in. And as you are all aware, there is what we call the Lusaka Agenda. The Lusaka Agenda essentially is to bring the global health initiative together, you know, putting them at the disposal of our member states, you know, to introduce or to bring into play a sort of what I describe as one country, one budget, one M&A, one report. Because by so doing, you introduce efficiency and you also avoid unnecessary duplication of effort. So within that Lusaka Agenda, we have been able to bring those global health initiatives together. And then much more importantly, through the Lusaka Agenda, we have also been able to introduce some sort of accountability mechanism and a scorecard so that we hold ourselves accountable as a continental institution. We are able to support our member states to hold key stakeholders accountable as well at the level of the member state and also for those global health initiatives, the Gavi, the Global Fund, the global financing facilities also hold themselves accountable, and we have to report back to our head of state and government every February in Addis Ababa, Ethiopia, so that, people know that you have to do it right. It's a mandate, it's a directive that's been issued by the highest political leadership on the continent. And the last but not the least is to support our member states, build their capacity to be able to implement what has been prescribed, in terms of managing these rapidly declining development assistance for health. So let me stop here so that others can also contribute to this discussion. Over to you, Madam Chair.
Yeah, thank you, Dr. Tajuddin, and thank you very much for all your time and for your availability to this webinar. So I'm going to ask Dr. Osundu, given your current role at the HIV and working under the Ministry of Health, the Federal Ministry of Health, how would you describe the current state of your health system, and what have we learned from decades of donor dependency? We all know that Nigeria is stepping out with innovative financing and trying to get increased resource mobilization. So it will be very important to understand what you are doing, especially coming from the pandemics like the COVID-19 and Ebola.
First of all, the presentation made by Raji spoke a lot about where we are as Africans and what we need to do better. But in terms of the response plan over dependency on the donor funding, of course, a lot of countries are now struggling to cope with the current changes. And something that is key, which for us in Nigeria, is I see something as if the Nigerian government, my coordinating minister, as if he's a prophet. And why am I saying this? I'm saying this because I think immediately he took over as the minister in 2023, he started some processes just to address improvements in our local funding, coordination of our spending, and also coordination of our responses to health needs. And so when this year, those things were already, of course, forming at that point, and we had what we call the sector-wide approach, which is a strategy where most of the funding, the coordination, the reporting will be from one particular source with different TWGs under that platform. Also, we have what we call the unlocking of the healthcare value chain, looking at how we can improve and promote local production of materials we need in country, health materials, unlocking the value chain, backward integration of technology. So some of these things were already at advanced level, even before the sudden change. We already thought as a country that it's come to a point where Nigeria will definitely, or Africa will definitely need to do more to sustain more and to survive more. So we thought as a country under the leadership of coordinating minister then, now he's still the coordinating minister, Professor Mohamed Ali Pate, to ensure that we are ready, we are well planned before that happened. So when this happened in Nigeria, what we rapidly do was just to activate those domains that have been created in 2023. So as a country, we looked into issues around, like I said, efficiency. How best can we do what we're doing before with less dependence on the donor? And if the donors are, of course, development partners or developer assistants are coming in, it has to be in line with the country priorities. And looking at a couple of things, all African countries too can learn from this. And I'm aware that during the PEPFAR or the initial PEPFAR announcement, or US government announcement, there are just about 3 countries in Africa, 3 countries that were poised, that were already prepared, maybe because of their sustainable system they've started with, or with some of the other challenges they've been able to overcome over time. And incidentally, Nigeria was one, or is one of the 3 countries as at then that had the form of plan to address some of these concerns. So the other 50 plus African countries also have to look at things in how best they can routinize their systems. And I always tell people that, because I traveled to one of the countries recently, and I discovered that at times you may think it's easier. You may think it's easier when you're dealing with small population. I may think it's harder when you're dealing with a bigger population. But in the real sense of it, it is just about the strategy. It's not about the size in population alone, and it's not about the numbers of people alone. So, for example, Nigeria is close to 240 million, and we have some countries that are less than 10 million, less than 5 million. But the strategy itself is not being determined by your population. You have to also consider a couple of factors. While we are discussing this sustainability, you also have to look at your economic sustainability, not just health alone, because everything is linked together. So it's a holistic approach, and African countries, the approach have to definitely keep doing what they will do to achieve the desired results. So these are my initial conclusions on this subject of discussion. Over from me. Welcome back, moderator.
Thank you very much. So let us now shift to what is working and where. So Professor Ngure, you work closely with communities. and researchers. So can you tell us what are some locally rooted and especially culturally responsive models that have shown promise, and how can we shift from top-down delivery to bottom-up design, especially in this current health landscape?
Thank you, Chair. I must say that working closely with communities and researchers reveals that locally rooted, culturally responsive models are most effective when co-created with the people they aim to serve. These models succeed by respecting local knowledge, systems, local governance structures, and community priorities. So when you're thinking about moving from top-down to bottom-up design, it calls upon us to move from centralized planning to core design, which is decentralized. We also want to think about moving from where the expert knows it all, like with the models that many of us are familiar with, to communities defining priorities. Actually, communities are the experts of their lived experiences. We also want to have indicators that are local, that where local people can define their success. We also want to think about moving away from uniform solution to contextual and culturally adaptive responses. We also need to institutionalize community voice by creating standing community advisory boards, like we have now in most of our researches, with decision-making authorities, and allocate a percentage of program budgets to community-led design and evaluation. And I'm sure that you have seen a shift for many of us who are doing budgets, that whenever we put these community interventions, they are funded and they are acceptable. We also need to fund flexibly and locally, that is, offer core funding and multi-year grants to grassroots organizations and support intermediaries that can channel funds to informal groups. We also need to build reflective practice and incorporate pause and reflect moments into program cycles. And like in the current scenario that we've been having, where we've been having a rat race, chasing one metric to another. How many people do you put on treatment? How many people are continuing? How many people are tested? But now with the changing landscape, we need to pause and reflect. When you're thinking, for example, about HIV prevention, it's not about the number of people we are putting on prevention. We want to pause and reflect and think, are we putting the right people on prevention? Are they the highest risk people? So that we can be able to reap the maximum benefit. And then allow for redesign of based local feedback mechanisms so that we can allow and are flexible to changing conditions. And as we do this, we also need to remember that we need to scale with communities, not scale for communities. I will now highlight quickly, I plan to highlight 4 promising approaches, but I will now highlight 2 in details. One of them, which I've been involved in, is the human-centered design for development, where the process starts with working with communities to understand their needs and co-design solutions. And the key feature of this approach includes empathy, iteration, and testing with community members. One of these examples include in Kenya, this HCD model was used to co-design maternal health services with Maasai women, adapting delivery models to their mobility patterns and social norms. And I'm sure in all our countries, because I travel a lot in sub-Saharan Africa, we have used human-centered design to look at challenges facing healthcare. And it's a very good design, because when you co-design with communities, then you are likely to end up with interventions that are more responsive and high acceptable to the local community. Another promising approach is community-led monitoring, and this is also advocated by another organization where I'm president-elect, which is International AIDS Society. And in this approach of community-led monitoring, citizens systematically collect and analyze and use data on service delivery, often in health sector, and can also be used in education sector. Key feature of this is monitoring is grounded in local priorities and cultural understandings of well-being. And here we have an example from Malawi, where CLM has improved HIV services by enabling community members to track clinic performance, leading to staff accountability and stockout reduction. The other 2 approaches I wanted to highlight, but probably I will not because of in the interest of time, and you can look them up, is participatory rural appraisal, and another one known as ABCD, which is asset-based community development. And key points we need to remember is, as these models have existed within us, but many of times we put them at the back burner. But with the changing landscape, both health landscape and funding landscape, we need to bring this back to the table, as they have shown a promise to shift from top-down delivery to bottom-up design. So thank you, and I'll welcome any questions either here or on the chat on any of the models.
Okay, thank you very much. And Dr. Bashorun, Nigeria has implemented some country-led reform Can you share concrete example where donor funding has been aligned or misaligned with national priorities, given your expertise? And how can we strengthen coordination and accountability, given when we look at the talk of Dr. Tajuddin, it's really very important that the governance as well as accountability mechanisms are put in place for efficiency.
Many thanks, Madam Moderator. So I will start by saying Nigeria started its HIV program, specifically HIV program in 2000, yeah, when we had a national program, national treatment program, then 100% funded by the federal government. And by 2003 to 2004, we had PEPFAR coming in. Then by 2005, we had a Global Fund coming in. And we've been running that program like that with their support, which for us, we have to keep appreciating them for their support. We've had them run like that till around 2020. So in 2020, the government, working with the donors, decided to form what we call the Alignment 1.0. And the Alignment 1.0 is just a way of prioritizing and apportioning different technical areas to people that will be able to perform optimally. So Nigeria has 37 states, which some people call 37 provinces or territories in other countries. So based on that, some of the states were divided along the PEPFAR support and along the Global Fund support. Then subsequently, even programmatic responses were also aligned into 1.0. That's under Alignment 1.0. And that lasted for 2 years. So in 2023, just before we wrote the Global Fund Round 7, the government decided again to start the Alignment 2.0. Now, Alignment 2.0 is further looking at how Global Fund will take more responsibilities. Government takes bigger responsibilities. PEPFAR also takes some responsibilities. In such a way, there won't be duplication, and there will be efficiency, and there will be standardized care or basic agreements on the standard package of care. That was done for 2.0, and we're still running 2.0. But above all, what now started again in 2023, which for me is even the bigger picture and the better picture, is running it under what we call the sector-wide approach, which is one of the key focus of the current government, where every single funding plan, one report, one conversation, and one plan. So we are trying to align even funding along that line to ensure that we have optimal gain from everything. So all the donor fundings, of course, we align with the sector-wide approach. And we also have what we call the health sector renewal blueprint, which is a blueprint guiding us on how to build efficiency into every health sector, not just HIV, malaria, TB, and malaria, TB, HIV, and the non-communicable diseases. So above all, we've looked at this from the historical perspective. We're able to build the case over time, and we've seen that definitely the direction is this alignment that we're talking about to address priorities. So definitely the future is bright, and I believe we can get that. But other African countries too should also think along streamline, like which was said that some countries are only dependent on development or assistance. So we can also start building some of these alignments into what we do. And I think the part of the challenge in Nigeria is that we have so many states and so many different groups. So we try as much as well to ensure that different partners working in different domains are able to align with one common country plan. And that country plan is what the SWAP will be leading and what everybody will fit into. So these are some of the key experiences and key innovations that we are putting in place, not as government alone, government with our development partners working together as one bigger team to ensure that as the government is doing, they are doing, and there's accountability framework backing everything up. Thank you.
Thank you very much. So we are having many questions on the Q&A chat. So I would like to ask to all the panelists just a final thought before we go to the final reflection. So please, 1 minute, starting with Dr. Tajuddin. Where do we begin? Where to start? And then I will also hear from everyone. And if we can have just 1 or 2 minutes per panelist, please, Dr. Tajuddin.
Thank you. I think for Africa CDC, it's always been that we are as strong as our weakest link. You know, nobody is safe until we are all safe. Whatever we do, we need to carry all member states along. Rwanda, Cape Verde, Botswana, doing it alone does not guarantee our air security. So it's really time for respected, trusted, action-oriented partnership to address this issue. Let's collectively build the capacity of those member states who do not have what it takes to quickly step into that space that's been vacated by the development assistance for health. You know, so let's do it together. Let's come together. Let's collaborate. Let's coordinate. You know, so that at the end of the day, we guarantee the air security of our continent and attain the so-called universal health coverage come year 2030. Thank you. Over to you.
Thank you very much, and thank you for your time. Thank you for having the time to come to this important webinar for Africa. So Dr. Ogbuoji, and please just 1 minute so that we can go to Prof. Gure and Dr. Bashorun.
Thank you very much, Madam Chair. So I think that we are, as African countries, we have great policies. Anyone who's worked in any health system in Africa knows that we have great policies. We have fantastic individuals and experts, but our systems are not designed. Our systems are designed in ways that make it difficult for these experts to produce good results. And we know this popular saying that a bad system will beat a good person every time. So I think that we need to take a step back and look at the systems that were designed. They were mostly designed to work on foreign aid. If we're going to shift into a new era, we need to think about how we redesign the systems to be able to work with domestic resources. I'll give you an example. For many
just 1 minute, please.
Africa, okay. Well, budget execution is a big problem here in Africa. Most ministries of health spend only about 85% of the money they get. So while complaining that there's not enough money, they don't spend all the money they have. That's a negative example. A positive example, Africa CDC has done a lot for COVID-19 and now doing more for health financing. And I think that we can do more in the lines of the positive examples and less with the negative examples. Back to you.
Thank you very much. Professor Gure, 1 minute.
Thank you. I'll start by saying that communities always have had a voice, but researchers and policymakers have not always been good at listening. Now circumstances are forcing us to go back to the basics and start listening so that we can get the priorities right as we budget. We need to ensure that community voices and subnational data meaningfully shape national priorities and resource allocation that will require both political will and practical and scalable mechanisms. There are many effective tools and mechanisms, such as participatory budgeting, citizen scorecards, national dialogues, and many other interventions, including community data platforms. But what is existing in all these countries is that we find that there are interventions and ways that are working, but we need a forum as African countries where people can cross-pollinate what is working. For example, we can find that something was working for health financing in Botswana needs to be shared so that other African countries can borrow from it, learn from it, and then whatever else is working from a different region is brought to is shared. So I think there is a need for a cross-pollination forum where countries
Thank you very much, Professor Gure. So Dr. Bashorun, please.
So I know I have 1 minute. So I would say there are some things we need to redefine our priorities. We need to redefine our definitions. We need to reduce parallel running of programs, parallel interventions. We also need to look at areas that give us the maximum gain, 80-20 approach in our interventions, and country priorities should be the key points. But like I said, any program that is parallel, that is standing alone, does not fit into the basic principles of health systems should probably be discouraged. And when we do that, definitely we should be able to use one common system, M&E system, to track all changes. And we should be able to use health workers that have wider experience also improve on other areas, not just parallel systems. Integration is key also. Thank you.
Thank you very much. And thank you all for your deep insight and passionate contribution. I know that we didn't have too much time, and we know that we are going to have many roundtables. So for me, the key takeaway are the urgency of resilient and sovereign health system, the necessity to move beyond vertical. So you just say integration, the power of collaboration, partnership, and also to be aligned and community-driven solution, as well as the opportunity to reimagine financing through equity, innovation, and Africa leadership. So thank you to our panelists, co-hosts, collaborators, and audience. So let us move forward and not as beneficiaries. As I say, we need to be the architect of our health future. So I'm going to hand over to the next session. Please, Pat and Wallace, over to you. Thank you very much.
Thank you very much. Thank you very much to our esteemed panelists. I think this has been great discussions, and now we move into audience engagement, and I will be inviting Wallace and Tolu to lead that point. Wallace and Tolu, please.
Well, thank you so much, Edward. Thank you so much. This has been a very engaging conversation for all of us here. There have been some questions that we recorded in the chat box, and I'm going to be asking 1 or 2 questions that I've recorded here. But we'll also be asking, I think we have about 25 minutes now to go. We'll also be asking our participants to this forum to please, make a note here in the chat. If you would like to ask a question, we can unmute you. Edward, I believe we can do that. So participants can ask questions to our panelists here. But the very first question that I want to ask our panelists, any of our panelists, there was a question regarding what lessons can we learn from the Rwanda example? Paul Kagame and the Rwandan people in general have been held to, when it comes to self-reliance in health. Apparently, a lot is being done in that country. So what can we learn from your different perspectives from the case of Rwanda? We can start with this question. Any of the panelists?
That's good.
I can.
So
Okay.
maybe I just say 1 or 2 things and others will speak. The lessons I've learned and we have learned as a country is that once you are determined to do, when you try to do the right and you're determined to do it, you can achieve it. And something else that I learned is, and I said it earlier in my presentation, is that your strategies is not a function of your population or your size. It's a function of your determination and how you run it. And Rwanda has been able to show us that once you are determined to make a positive change, in terms of donor fund management and your own budget management, you can achieve it. So it's a lessons learned that we can all try to practice in our different countries. Over from me.
Yeah, and
Go ahead.
I agree with that. I'll also say that one other thing that Rwanda has shown is that having political will is key for any kind of change to happen. They have political will right from the presidency all the way down, and that really galvanizes action and pushes people where they need to move. The other thing that I noticed from Rwanda, and anyone who's gone there will know, is that they move very fast when it comes to the health systems work. Once a decision is made, all hands on deck move towards implementing that decision. So that's one thing that a lot of other countries can learn, that once a decision is made, you should just move very quickly and then learn and iterate as they move.
Well, thank you so much. We have a question, a request for a question by Claudette Leod. Claudette Leod, I'll come back to you. Edward, you might want to unmute her in the meantime. But another question that we recorded in the chat is related to the capacity of absorption, the absorption capacity of our government. For example, when you look at NGOs that are currently or that were intervening in the health sectors in our countries, funded by the US government, USAID and others. You look at the level of salaries paid to doctors, comparing that level of salaries to the level of salaries that the civil servants of different African countries are receiving. There is a mismatch. So the question is really about the countries, the African countries, where these doctors were being paid so much. Will they be able to be absorbed by the governments? What's your sense about that? What are your perspectives? We can probably start with Dr. Osondo.
Thank you very much. I think that, yes, the salary mismatch exists in most countries, and NGOs or implementing partners, as most people call them, pay much more than what the government pays. But the government is not going to change its salary structure to accommodate NGO salaries. So I think that is probably not going to happen anytime soon. The real question here is whether the government will create systems that will allow them to engage the services of these CSOs. So if USAID was able to pay a particular NGO to implement services, will the government be willing to do that? Now, the NGOs need to also understand that the government might not be able to pay a lot of the money, but the government should also understand that a lot of capacity reside within these NGOs to implement and implement very quickly on specific tasks. And so there needs to be some understanding, maybe some arrangements like public-private partnerships or other arrangements that would allow the system as a whole to benefit from the speed and agility of these organizations, while also looking for a way to ensure that we de-risk the whole enterprise for the government itself, so the government does not take on more than it can handle.
Thank you so much. Dr. Bashir?
So that's an interesting question for me to answer, especially because I'm a core government official and I understand how the government processes work. So truly, the government has what we call a salary structure. Government has what we call appropriation and approval. So I don't see any, at least maybe my country, changing the salary structure overnight because of some subset of the overall country system. So for example, it's not only doctors, we have other health workers too. It's not only on that line too. If you go to engineering, you have other people under the Ministry of Works. If you go to schools, you have people in educational institutions. So I don't see it going to be rapid. I don't see a rapid change in paying people's NGO salary. It's not going to work because it's going to affect other sectors in the country. So health is not the only one. We have to look at it holistically. Then about what we call salary review overall, which we have a salary and wages commission in Nigeria that will determine that. So NGO salary will not influence directly what government keeps paying. But I think at this point, everybody should, according to what we say in my parlance, everybody should cut their cloth to their size, and we now move ahead together, because a lot of people working in the system currently are not working with the NGOs, and that money is no more there. So we have to reprioritize and what we call structural adjustments to ensure we deliver on everything. Thank you.
Thank you so much. Thanks so much. Professor Ngure, would you like to add anything?
Yes, just to say that the motivations for people working in government and those who work in NGOs are sometimes different, especially in my country. That there are people who opt to work for government, either for the greater good, or even that the governments are more stable, that you have your what they call permanent and pensionable, so you are more predictable. People who work in NGOs usually work in 1 year or 2 years, so they are paid for big salaries with huge gratuities because it's uncertain, as we have already seen. So I'm not sure, and I don't think the government should change their salaries based on the NGO salary. They have their policies, and they also unions that work with the government to bargain on these salaries. But actually, the bigger question is, how will government fill in some of the slots that were being provided? Because there are other officers, for example, people who are keeping health records, or a certain number of nurses or doctors who are probably manning some services. How do they fill in some of those critical slots? So I think it calls for them to think inwards and look at how they can be able to allocate funding to hire more staff to ensure that there are no gaps. And as we had said about integration and all those other interventions.
Thank you so much. I really appreciate this. So we have noted Claudette Leod. Are you here? Can you unmute yourself and ask a question? And we're also noting the names of Olumuyima Wa and Adaobi. We'll be getting back to you for your questions. Go ahead, Claudette. If you're able to unmute yourself. No? Okay. Let's try Olumuyima. If you can unmute yourself and ask a question.
Afternoon.
We can hear you.
Distinguished panelists and the organizers of this event. I'm very impressed about what I've heard today. So my question was, how can we drive prioritization through government will for access to healthcare itself? Because what I've seen over the years working in health insurance as a health finance person, working with government and the private sector, is that without prioritization of access to care for all citizens across the African continent, we can address the major issues, health indices. I give Nigeria as an example. The last 30 years, we've had very poor indices as regards maternal mortality, infant mortality, despite voting increasing figures to healthcare every year. So how can we achieve this across the African continent, driving prioritization of access to care through health insurance for the citizens with mandatory health insurance schemes? Thank you.
Thank you so much. Can you briefly say who you are with, your name and?
Yeah, I'm Dr. Olumu Olusoya. I'm the CEO and managing partner of Signal Health, Healthcare Consulting. Yeah, thank you.
Perfect. Thank you. Panelist. Dr. Osondo, would you like to start?
Sure. So I think that it's no secret that there are lots of gaps in the system, and different communities face different levels of access barriers to care. I think that what has happened over time, especially with the fragmentation of financing that comes with donor funding, is that we have had very strong communities develop. So you have the HIV/AIDS community, you have the malaria control community, you have the vaccination community, and these communities typically advocate for increased access or financial and geographic access to care for the people that are concerned, that they're concerned with. The problem, though, is that we're not looking at the whole individual. We're not looking at the whole person. And so the question remains: if you save a child from dying from malaria and the child dies from HIV, the child still died, right? And so we need to think carefully about how we improve access. And so I agree with you. We need to prioritize access to care for the individual, the human, and not just the disease control programs. But how do we do this? And I don't think that we've been successful in doing it in many countries. We do have examples of where that has happened. Ghana is an example. Rwanda is another example. We have South Africa. So it is possible to do that, and it will take a lot of advocacy from civil society organizations. It will take also advocacy from professional associations like nurses associations, doctors, pharmacists. And I think that if we all speak with one voice, that it will be very hard for the politicians to ignore. I'll give an example from Nigeria. Nigeria has a National Council on Health that happens every year. And the decisions that are made at the National Council on Health are they're binding in many ways. And it's very difficult for even the Minister of Health to change those decisions if without getting some pushback. So if the health community comes together and pushes for improved access to care, which now I think is the most sensible thing to do, now that most of the funding will be coming from domestic sources, I think that it will be possible to get to the goal that you just mentioned. Over.
All right, thanks so much. I think I will give the question to Professor Ngure, then we'll go to another question. Dr. Adebayo, you'll have a chance.
Yes, mine is just to quickly highlight that all the problems that are being faced by countries are not unique. They have been faced by countries in other regions, and some of the regions have come up with innovative strategies. So what they need, and I had said earlier, is about cross-pollination, seeing what lessons can we learn from Ghana, what lessons can we learn from Rwanda, what lessons can we learn from India or Brazil for that matter. And when we take those lessons and customize them, we'll be able to address most of the problems. Thank you.
Thank you so much. Thank you so very much. We can go to Claudette now. Claudette, I think you are able to...
Let me quickly say 10 seconds.
Go ahead.
Yeah, mine is just to... I agree with Professor and of course Osondu Ugoji. I can pronounce his name well because we are from the same country. So my addition to that is at times, right, while you are prioritizing, also ensure that your data quality is optimal. Because some of the figures, either through poor reporting or poor estimates, you may not really understand your body. So as we are prioritizing, let's also focus on reporting and report all, and we analyze and show that the data, in terms of you're saying maternal mortality, is the exact figure we are getting. Let's go back to that one. So you can actually quantify your need in real sense, not estimated sense. Thank you. That's just an addition.
Thank you so much. I appreciate it. Claudette, we can go back to you now.
Okay, thank you, everybody. Hi, my name is Claudette Lloyd. I'm from Zimbabwe. I work as the Knowledge and Advocacy Manager with an organization called Tree of Life, and we provide mental health and psychosocial support services, mostly to vulnerable rural communities, because we have a big shortage there in Zimbabwe in terms of like counseling services and psychologists, psychiatrists, etc. My question is really around how do we prioritize providing mental health services to our communities across Africa, because realistically speaking, the funding situation is dire. It's dire, and we don't even know when we'll have enough money to make up for the funding freezes that are facing us. Secondly, the World Health Organization has stated that depression is actually the world's second biggest killer, depression alone. And that will also include anxiety, stress, PTSD. Just to give an example, we were funded very largely by USAID before the freeze, and our work allowed us to help thousands of people reduce their mental health symptoms. You know, we used a World Health Organization tool that was able to help us track that, and over 90% of our participants were healthier mentally. They were able to function in their communities, but above all, we believe that this helped to prevent illness. So if depression is the second greatest killer, surely we should be working towards preventing people from getting ill. So I think my question is, how do we prioritize providing mental health services across Africa so that instead of, yes, it's so important that we respond, that we provide the health services because people will get sick. But we can prevent so many illnesses just by giving people practical tools to manage stress, to be happier, and to fall, and probably not to fall sick. So yeah, I think that's something, as we're talking about reimagining health, I would love to see the forum really placing a lot of emphasis on prevention through the provision of mental health services. Thank you.
No, thanks so much. This is critical. I think part of the question is also whether our countries, our governments see mental health as a priority, and if it's a priority, are they able and willing to fund to make those happen? And so, given the time constraint that we have, we should probably give this question to 2 panelists maximum. Let me, Dr. Nguri, would you like to start? And then after that, Dr. Osondu, then we'll take 1 or 2 more questions, and yeah, we'll stop.
Thank you. Thank you for that question. That's a great question. So mental health, as we are aware, affects a lot of health, including all the interventions we are proposing, whether it's diabetes treatment or HIV, whether people adhere or whether people come to hospitals. The traditional approach is that we have had vertical models, and I'm speaking very fast, in the interest of time, where we have a clinic separate for mental health. But as we are talking about integration, there is need to integrate mental health, where even somebody in OPD could be screened for depression, and depression has very easy screening tools, as we know, PHQ-9 and the others. So it is important to integrate mental health in all service provision, including FP, MCH, and all other services. But also want to say that there is one person I would probably want to refer you to. I know the person who asked the question is from Zimbabwe. There's a Dr. Dixon Chibanda, who has come up with very good models of task-shifting mental health care to lay workers. So I would encourage you to look at that. And those are models that could be adopted in other countries, so that it's not only the psychiatrist or the mental health nurse who is trying to screen people. There are simple tools that can be used. So I'll stop there. And I know I've spoken fast.
No, that's fine. It was fast but audible. Yeah, let's go now to Dr. Osondu.
Yeah, thanks. To extend on what Prof just said, I think that not just mental health, but in general, preventive services, I think should be prioritized. The more we can keep people out of the hospitals, the better for us, because then it will be cheaper to provide the care that's needed at the hospitals. But we will need to also pay attention to the preventive health, the public health policies, and all the other things that are necessary for to keep people healthy and not just respond to sickness. So I fully agree with your submission. Thank you.
Yeah, thank you so much. We'd like to go now to Adaobi. Adaobi, please go ahead.
Yeah, thanks everyone for the very rich discussions. Building on the conversation so far about efficiency, I just wanted to hear the thoughts around how we're exploring the use of artificial intelligence to increase efficiency and ultimately improve impact of our public health programs and strengthen our health systems. For example, one of the first major impacts we felt from the funding freeze was overburden of healthcare, of public health facilities. And we know that one of the major advantages that artificial intelligence provides is increased efficiency to reduce the burden or redundant tasks for humans and healthcare workers. So I'd like to just hear how we're trying to leverage that on the African continent to like what she said, to forecast breakouts, to improve efficiency of supply chains, even like what Professor Kenneth said about ensuring that we don't have just numbers of people on PrEP, but the people who need it. At CROI, we've seen presentations on how they are talking about artificial intelligence for precision prevention to ensure that we're targeting the people who really need it. So how are we thinking about using artificial intelligence, building the capacity on our African continent, our healthcare workers, to be able to buy into and leverage it for stronger healthcare systems? Thank you.
Thank you so much. Thanks so much. Given the constraints of time, we'll go to only one panelist for now. Dr. Adebo Bura, is it okay for you?
Yes, it's okay. So I'll start by saying, of course, a lot of countries in Africa are not yet advanced in artificial intelligence. That's the starting point. But a lot of countries are trying to achieve more on that. For example, we have a model that in my country, of course, that we are trying to predict those patients that will be lost to follow-up. And once they're lost to follow-up, once we can make that prediction in artificial intelligence, the teams quickly follow up with the linkage to care team or follow-up teams quickly do a follow-up on how they're going to prevent them from being out of care. Another one that we're working on is also to predict the conditions that will happen. If ABC happens, what will happen to the clients? How can we respond? Just today, before this meeting, I had a meeting with one of our partners leading on this. We had a roundtable. So this is like my second roundtable today. And we had a roundtable on discussing how we can use it to predict every step in the PMTCT, prevention to modern to child transmission, looking at it from geographical perspective, structural development, or structural challenges, using artificial intelligence. And how it works is to just pop up in your system, your central database, to say, go to XYW, whereby you can be able to address some of these concerns. So we are trying to use some of it, but like I told you, most of them are seeing the teething phase. They've not yet gotten to that advanced level. But as a country, we get there. I definitely will get there. Thank you.
Thank you so much. And as you can all see, It's really unfortunate that we cannot allocate enough time for all of these good and loaded questions, but hopefully we'll create another opportunity where we collect all the questions and respond to them. I was going to go to one last question, Corinne, if you don't mind, one last question from Olumuyiwa, and then we can go back to the facilitator. Olumuyiwa, if you can unmute yourself and ask a question. Yes.
Well, thank you so much for the very, very detailed presentations and all that has been said. I was wondering, considering I am Olumuyiwa Desmenu, I work around here in the US, and I currently work on evaluation as the evaluation specialist on nutrition education program, and for my university. I am curious to know if we have started thinking of going back to indigenous knowledge. I know AI is very good, insurance is very good, and all those things are very good, and they will make impact in health. But have we started thinking, especially considering the current funding costs across globally that has affected everything about research, have we started thinking about indigenous knowledge and possibly how communities were managing health prior to now? Those looked cheap, and they seems, I'm not sure whether they are very effective, but at least they kept communities in health. Growing up, I can't remember seeing so many people with mental challenges, or maybe there was no data then, I'm not sure. But have we started looking at how we can leverage on indigenous resources, traditional resources, to see if we can help our health system? Maybe they could be cheaper than all these Western approaches that we need so much funding to do. I'm just curious. Thank you so much.
Thank you so much. And for this one, we'll go to Professor Ngure. And Professor Ngure, you will have the last response, and then we'll go to other colleagues. Thanks.
Sorry, probably I missed that because I was highly responding to a lot of questions on the chat. Maybe you can summarize quickly that for me. I'm sorry for that.
Oludua, would you like to just summarize quickly for him?
So I think I got the question right.
Oh, okay, perfect. Go ahead.
The question is, how can we use our local systems, local approach that may be better or more efficient than always using the Western approach? I think that's just the summary of what he said. And yes. I would say, yes, I would say it's a good one, and I'll make my own very simple. As Nigeria, we are working towards unlocking the healthcare value chain, number one. There's a new policy by our president, which is local content policy, where you must also examine what you have locally. If it works for you, keep using it. If it doesn't work for you, you can, through our PPP, get the Western one, but you must be able to transfer that technology back home to improve what you need to improve on at home. So we're already thinking along that line. And like Mr. Muyiwa said, definitely you start from inside, local. Then if it can't solve the problem, you can now go external to get the other support to beef it up. Thank you. Over.
All right. Thank you so much. Thanks so very much. And at this time, I'll turn the microphone to my colleague, Pat, for closing remarks and just conclude us. Thank you.
Yeah. Hello, everyone. Thank you so much for such rich discussions. Today, discussion has made one thing resoundingly clear. The time to reimagine and reshape Africa's health system is not in the future. It is now. And we've heard compelling reflections on the urgency to move beyond traditional models of dependency. And we've begun to unpack really the immense opportunities that lie in building systems that are resilient, locally anchored and people-centered. And the path to a self-reliant healthcare future will demand courage, collaboration, and a redefinition of leadership. One that values evidence, equity, and innovation. And it was clear from all the panelists, these themes were recurrent. So let us take today's energy forward. And we hope that we will commit not just to more talk, but to bold, coordinated actions. And this journey has begun. And working together, we will rewrite a new chapter for health in Africa, one that is rooted in ownership, sustainability, and dignity. Thank you so much for contributing to this vital conversation, and we look forward to continuing it in the next roundtable. But as we draw to the end of our first roundtable, I want to express our deepest gratitude to everyone who made today's dialogue both powerful and purposeful. To our moderator, thank you for guiding the conversation with clarity, curiosity, and courage. And even that technological glitch didn't stop you. Your thoughtful facilitation created a space for truth-telling and bold visioning. To our distinguished panelists, your insight have illuminated not only the challenges we face, but also the immense potential within our reach to transform Africa's health systems. And to the conveners, myself, Dr. Tolu Oladele, Mola Pofu, Wallace Coulibaly, and Dr. Eddie Oladele. Thank you so much for your leadership in bringing this forum to life and for reminding us that transformation starts with deliberate conversation. We couldn't have done this without the sincere appreciation, support of our sponsors and partners, and their belief in the vision of a self-reliant, equitable, and resilient African health future makes this series possible. Your support is really helping to catalyze change across our continent. And most importantly, our audience, your engagement, your reflections, and questions today have affirmed that we are not alone in this pursuit. You represent a wide range of stakeholders across our continent, from the diaspora to civil society, and your participation is a signal that broad commitment to this cause has started. And I'll stop here and I'll turn it to my colleague, Mola.
Thanks, Pat. And yeah, I can't say much. I see we're at time. Everyone has been acknowledged, but I do want to at least highlight a few takeaways that came from this discussion. This was an opening roundtable, as you are all aware. It's always difficult closing a session where you have such an interactive, engaging audience and panelists. But just a few reflections. I'll just highlight 5. I actually had a thesis in front of me. But the first thing that I just want to highlight, which came from this discussion, is that we've made gains, definitely from donor funding, and we need to sustain those. The second one is that our health problems in Africa are growing. With 70% cut in funding that we previously had from our donors, that also further increases the challenges that we're likely going to encounter. As we're from Africa CDC, 150 outbreaks annually, expected to go to more than 200, and more than 4 million people dying as a result annually. That is a challenge that is, as the continent, we need to address. The third one is that as Africa and as the people, we should do more, and we can do more. We had that at the level of heads of state, led by His Excellency, the President of Rwanda. Some initiatives and directives have already been made. We have even an agenda called the Lusaka Agenda. We need to institutionalize that and operationalize that. It's the only way we can address our challenges in Africa. The fourth is that we do have the answers to our health challenges. We have the right policies. It's just that our services and our systems have sort of been misaligned as a result to resources which are tied to certain expectations from donors in particular. The communities have the voices. And I did like what Prof. Ngure said, that as researchers, as implementers, we sort of haven't been reasoning well with our communities who know what needs to be done to address the problems that they have or encounter. And we need to go back to the communities, work with them, co-create with them, and develop strategies that are tailored to their needs and that are applicable to their communities as well. The last one is efficiency. This was the buzzword. It came from almost everybody. And this is actually a great segue to our next session, or roundtable, which will be coming in June 25th. Please register. Some of you who had questions around how we can be efficient. Can we use technology? Can we use AI to be efficient? Integration, transparency, accountability. Your answers will be answered on the 25th. So please make sure that you are registered, you mark the date, and also for the next roundtables, which will be coming in July and August. And don't forget to stay tuned to our online page, the Africa Health Catalyst Forum, which is hosted under the CEF's website. You'll get more updates. I want to thank all of you for your participation. We look forward to meeting you and talking to you again in about 4 weeks' time. You all have a great rest of your week. Thank you so much.